Hello, everyone, and welcome to another Helios Speaker Series. It's really nice to have you all with us today, and thank you so much for joining on what is probably a really nice day in most of the Northern Hemisphere, well, Southern Hemisphere probably as well, for the ones joining from Tanzania. For those not familiar with Helios yet, Helios is a 5-year project funded by the European Union with the aim to standardize the care for hemoglobinopathies by bringing together experts in the field through training capacity and networking opportunities, and to then translate these into clinical best practices. Whilst the focus is mostly on Europe, we currently have over 200 members from all over the world because we fully acknowledge that experts come from everywhere. So if you're interested in joining or in learning more, go to our website heliosaction.eu. On our website, you also have more information about this Helios Speaker Series. For example, the upcoming speaker in June will be Dr. Maddalena Casale. If you're interested in joining her presentation on avascular necrosis in sickle cell patients, then please register for this webinar individually. It's not possible to bulk sign up for the webinars, but you have to sign up for each webinar individually. If you missed any of our past webinars, you also have the opportunity to watch the recordings from previous webinars, for example, with Professor Immacolata Andolfo or Dr. David Williams. And today, I'm very excited to welcome Dr. Siana Nkya from Tanzania. Dr. Nkya is a senior lecturer in the Department of Biochemistry and Molecular Biology at the Muhimbili University of Health and Allied Sciences Hospital in Tanzania. She is also the coordinator of the Office of Sponsor Projects and the head of the Genetics Lab. Dr. Nkya has over 15 years of experience in molecular biology and human genetics with a particular focus on disease prevention, diagnosis and treatment through advanced genomics. She co-founded the Tanzania Human Genetics Organization and is currently their first president. Today, Dr. Nkya will provide an update on Sickle in Africa, which is a consortium with the aim to facilitate research into sickle cell disease and to translate these findings into healthcare best practices. Dr. Nkya, thank you so much for joining today. We're very excited to have you with us, and we very much look forward to your presentation.
Thank you very much, Stephanie. Greetings from Tanzania. Thank you so much for joining the meeting today. Stephanie, just confirm if I have to share my screen or we will run the slides.
If you could share your slides, then you're in control of them. That would be the easiest.
Okay, great.
That would be wonderful. Thank you.
Okay, so can you confirm if you can see my slides?
That's perfect. Thank you very much.
All right. So thank you very much, Stephanie, again for having me today. Let's see if I can put them in. For having me in this lecture series organized by Helios. I really appreciate you inviting me to give an update really on Sickle in Africa. And I should just say that, as you can see, it's a collaborative and multidimensional approach to conduct research and improving health in Africa. So just a bit of background about sickle cell disease burden. So at the moment, the estimates stand at about 500,000 babies on sickle cell disease annually. And most of these babies, up to 75% of individuals with sickle cell disease, reside in sub-Saharan Africa. Sickle cell disease was recognized as a global public health condition by WHO in 2006. And without proper interventions, 50 to 90% of children with sickle cell disease die before their 5th birthday. On the right, we see a global map which presents birth incidences, both males and females, which was published by Thompson et al. In 2021. And we can see that most of African countries really have high prevalence of sickle cell disease. So what I'm going to present today is based on the paper that we as SickleInAfrica published last year in August to update on the progress that we have made as SickleInAfrica Consortium. So as you can see, this is really a collaborative effort. It's a lot of work from different people, as I will highlight. So SickleInAfrica Consortium started in 2017. This was the first phase, 2017 to 2021. And we had at that time 3 sites, 3 implementing sites, Ghana, Nigeria, and Tanzania. And we had Sickle Pan-Africa Research Consortium Hub. This was coordinated from Muhimbili University in Tanzania. And we had Sickle Africa Data Coordinating Center, also known as SADC, which was based in University of Cape Town in South Africa. And this phase was supported by NIH, the NHLBI, and it was 1 award with 2 awards with sub-awards to the sites. After that, when we saw that this was successful, we applied for the second phase. And this time we aimed at expanding to additional sites. So we now have Ghana, Nigeria, Tanzania, Mali, Uganda, Zimbabwe, and Zambia. But we also have 2 coordinating centers. We have SickleInAfrica Clinical Coordinating Center, again based in Muhimbili University in Tanzania. And we have the Data Coordinating Center in University of Cape Town, South Africa. So the second phase was awarded in 2022, expected to end next year, 2026. And this award was a bit different from the first one. So the sites did apply, and it was a competitive. It was a competitive application, and the sites that were awarded became part of the consortium. And the coordinating centers as well did submit applications. So the main goal of SickleInAfrica Consortium is to serve as a platform for African countries to work together to implement regionally appropriate standards of care for individuals with sickle cell disease. So this includes research and other activities, improving standards of care, guidelines, and others. So on the right, you can see this is the map of the sites that within the SickleInAfrica Consortium. And we present both the sites that were there in the first phase and the ones that are present in the second phase. So one of the main aims of both phase 1 and phase 2 of SickleInAfrica was to establish a registry for individuals with sickle cell disease in this region. And in phase 1, the aim was to register at least 13,000 patients with sickle cell disease in the 3 countries. In this phase, we aimed at adding to that number. So this includes both the old and the new sites to register additional 21,000 patients with sickle cell disease. But we also wanted to be able to start integrating the research that we are doing across the region to the registry, to contribute to the data that we collect within the SickleInAfrica registry, but also utilizing the registry for conducting research that is aimed at improving care for individuals with sickle cell disease. In phase 3, our future plans are really to be able to sustain the registry and to expand. As you can see, although we aimed at having 34,000 registered in this registry, that's really just a small proportion of the patients with sickle cell disease that we have in this region. So we hope that we'll be able to sustain and expand the registry at national at national and consortium level, but also including other countries that will be interested to join and be able to support future research studies. As we all know that registries are really a resource, a great resource for research, but also a great resource for planning for interventions and preventions, which is really critical for regions like sub-Saharan Africa. So at the moment we have exceeded the target that we had set for phase 2. We now have over 38 patients with sickle cell disease registered in this SickleInAfrica registry. And for research, the first phase was really to help us start planning for research that is meaningful for us in the context of sub-Saharan Africa for sickle cell disease. And phase 2 to be able to launch some of the studies that we planned in phase 1 and others, and be able to implement them during this phase that we are in. And we are hoping that beyond this phase, we will be able to complete the studies that we have planned and started to implement in phase 2, and also initiate some new research studies, as I will show later on. So as I said earlier, the phase 2 has a number of countries, 7 countries in total, that are taking part of the SickleInAfrica consortium. And as I said, each site did submit an application with their focus, with priority research that they would want to implement in their sites. And these were really in main 2 categories. We had cohort studies and implementation science research. And after the awards, we decided that we wanted to conduct cross-consortium studies that will be implemented across the consortium. And we agreed as a consortium that we will focus on these cross-consortium studies. So we had to put in place a process of selecting which studies are a priority for us as a consortium. And what we did was, in collaboration with the Data Coordinating Center and the sites, were to design a scoring matrix tool, and then we requested the sites to present at the steering committee. The steering committee is a decision-making body within the consortium, and it is comprised by the principal investigators from each site and the coordinating centers. So each site presented their projects, and there was voting. And then from that, we selected the studies that we wanted as a consortium to conduct at consortium level. Thereafter, we went on to develop protocols, now based on the fact that these are now cross-consortium studies, and presenting them at different bodies, including the steering committee again, but also to National Institute of Health, NHLBI, bodies, the OSMB and DSMB, for their approval, and before starting the implementation. So we decided to conduct 4 studies, 2 cohort studies and 2 implementation science research studies, as I will show later. So the first study that was selected was newborn screening. This was a priority study for obvious reasons, because we all know that newborn screening has been an important intervention in the developed countries. And through newborn screening, have been able to observe decrease in mortality and morbidity of children with sickle cell disease to more than 50%, in other places up to 90%. So it was obvious that we needed to strengthen the ongoing studies that were being conducted in the region as pilots, newborn screening or programs, to see how we can actually conduct this at consortium level, and really see and address some of the limitation factors that we had already started to learn from the different studies in this particular consortium study. So this study is led by Nigeria, by Professor Obigaili Nodu, And the main focus is really to see how we can utilize point of care testing with dried blood spots to implement newborn screening. This is because one of the limiting factors for newborn screening, especially in developing countries like ours, is really access and cost. So this is ongoing. We are actually coming to the end of this study, and we have been able to publish a protocol that is accessible at BMJ Open, and we're planning to publish others, including one manuscript that will show the different tests that we have done, including the point of care DBS test, qualitative aspects of newborn screening, which is really capturing different views and opinions of key stakeholders of newborn screening on how we think that we can actually improve the access and implementation of newborn screening across the consortium, and policy briefs that will be informative, especially for policy change. In phase 3 or in the future, some of the things that we are hoping to do is being able to integrate newborn screening services in existing health systems, incorporate newborn screening interventions in the existing standard of care guidelines, scale up newborn screening to national level at each site, perform molecular and genetic studies, and also to be able to conduct further implementation research to identify babies who may benefit from advanced therapies like exchange transfusion, bone marrow transplant, and gene therapy. The other studies include another study that was implementation science research was penicillin and hydroxyurea. So really looking at the enhancing access and utilization of these interventions that have been proven to really modify the disease. So this one is pending implementation, because we decided again after choosing the 4 studies to prioritize 2, one cohort study and one implementation science study. So the other study that was selected, so for newborn screening, that was the implementation study that we prioritized to start with. And the cohort study was malaria observational study, which is we have just started to implement. And we are hoping to really collect key information about what we observe in terms of incidences of malaria cases across the consortium, which will be informative to plan for proper interventions and inform standard of care guidelines or guides or procedures for sickle cell disease patients in terms of managing malaria in patients with sickle cell disease. It is known that although the carrier for sickle cell disease are protective of malaria, but patients with sickle cell disease, when they contract malaria, it can actually become very severe. And you can imagine that sickle cell disease itself is a hemolytic disease, and malaria is also hemolytic in the sense that the red blood cells are being distracted, we have a lot of hemolysis. So it's really important for us to understand better how to manage malaria in patients with sickle cell disease. The other cohort study that was prioritized is pharmacogenomics of pain treatment outcome. And this is because we all know that pain is one of the most commonest but also very severe manifestation of sickle cell disease. And there are different interventions, drugs that are being used for managing pain. So we wanted to understand better, one, how we manage pain across the consortium, but also to look at the different genetic variants across the consortium that may influence pain treatment outcomes. So in the future, we are hoping that we can continue these studies, because this is really like the first phase, to be able to conduct further research to understand these aspects better across the consortium and beyond. So just a quick update for the newborn screening study that I said we are in the final stages of completing So this is what we have been able to do, the screening that we have been able to implement across the consortium. So we had a preliminary phase where we piloted 100 babies, screening of 100 babies across the consortium. And we had phase 1, which was now scaling up the screening after what we had observed in the preliminary phase. And then after the phase 1, what we had was qualitative phase where we, as I said, we are collecting information on what are the factors and barriers and challenges that may influence the uptake of newborn screening as an intervention across the consortium. And then for malaria observational studies, so we have started enrolling in 2 sites, but and the other sites are finalizing getting their RB approvals. But this is what we have planned to enroll in terms of different age categories. So we have 3 categories. We have 6 months to 4 years, and those are the numbers. And then we have 5 to 10 years, and then we have 11 to 17 years. We're hoping that we'll be able to collect key information, so clinical information, some laboratory parameters, measurements that will inform us on the incidences of malaria, but also the clinical manifestation for those with malaria. Apart from research, we all know that ultimately we do research so that we can improve care for patients with sickle cell disease. So one of our strong arm has been standards of care, enhancing standards of care for people with sickle cell disease. In phase 1, we did develop standards of care guidelines for sickle cell disease, and this is available in our website. In this phase, we managed to launch the guidelines across the consortium, and also scaling up the dissemination of the guidelines across the consortium. We also have started to identify different standards of care issues related to cross-consortium studies. And we are hoping that in the future, we will be able to scale, to do an upscale of standards of care much more to across the consortium, but also to integrate research findings that we are developing or we're implementing to strengthen the standards of care delivery across the consortium and in the region, but also integrate standards of care practices at national level. We also are hoping to integrate registry to support delivery of standards of care. As I said, the registry is really the source to help us to plan better for interventions and prevention. So just to say that the different arms are led by different individuals across the consortium. So the standards of care is led by Dr. Vivian Paintsill from Ghana, with help from Ms. Josephine in Tanzania. And we have members of the working group from across the consortium. And then we also realized that we are not able to implement any activities, being research or even developing standards of care guidelines without proper skills harmonization across the consortium. So in phase 1, there were efforts to build capacity for healthcare workers in the 3 countries that were involved. In this phase, that initiative has been implemented further. And we also tried to map existing skills across the consortium so that we can share resources, leverage on different expertise that we have across the consortium, but also see existing gaps, skills gaps that we can build on. We are hoping that, and one key thing that we have also done as part of skills harmonization is really to build capacities to implement the research studies that we have selected across the consortium. So in the future, we are hoping that we'll be able to continue this initiative to leverage and sustain existing skills across the consortium and beyond, to continue to train different cadres of people, health personnel, researchers, scientists, data scientists, and laboratory personnel and the like, so that we can continue to improve healthcare delivery and implement research across the region. So again, Skills Harmonization Group is led by Professor Abigail Nodu in Nigeria and supported by Ms. Josephine. Yeah, so I really did pick a few, but we do have other working groups, including management, as you can imagine, which is led by the principal investigators and program managers and coordinators across the consortium to coordinate different activities. We also have a sustainability working group that is really working on mapping how we can sustain the different activities that we are doing across the consortium. Again, this is led by the PIs and supported by the two coordinating centers. With that, I would like to thank the SickleInAfrica Consortium. This is really, as I said, the work that is being contributed by many, many people across the consortium. We thank the NIH for supporting this work, NHLBI, Sickle Cell Program of Tanzania, where I'm based, and all partners. Thank you very much.
Thank you, Dr. Nkya. That was really a fascinating presentation, and thank you so much for providing an update. For those who want to ask a question, if you could either raise your hand or ask the question in the chat. Maybe for me to start off with, because you mentioned obviously the introduction of standard of care guidelines and that you're currently operational in 7 countries. And I'm curious, what hospitals are currently members of the consortium? Because I'm conscious that obviously the bigger teaching hospitals like Muhimbili Hospital, they have more resources than the smaller district hospitals. Which hospitals do you currently work with? Are they bigger university hospitals or also the smaller ones? Or?
Yeah. So yeah, you are right. So because of the limitation of resources and of course the logistics of running the project, at the moment most of the hospitals across the sites are either teaching hospitals or university hospitals. So so for example, here in Tanzania we have Muhimbili, but we also have another hospital, Bugando Medical Center, which is in the Lake Zone. In Uganda, we have Mulago, I think, if I'm not mistaken. We have Kwame Nkrumah Teaching Hospital, and then in Abuja. So mostly really teaching hospitals. But of course, some of the sites have managed to also pick a few peripheral health facilities to be part of the study as well, for the same reasons that you are mentioning, that to start to build capacity. And we know that, for example, most of the people with sickle cell disease would really access mostly the lower level health facilities rather than the referral hospitals. So one of the things that we are hoping is really to be able to decentralize these services to that level. And that's also one of the aims for newborn screening, to be able to screen to that level. And that's why we are looking at having point of care testing, which is more accessible and easy to manage, so to speak, so that we are able to go to those levels. But also the training of healthcare workers is aimed to go. We have started aiming really to build capacity to every level, to the lower level, so that we are able to have these services delivered at that level. And we are working with other networks as well. So other networks, other people who are doing similar work. So, and one of the partners, for example, is Pen Plus, who is delivering services for including sickle cell disease at the lower level. Yeah.
That's fantastic. Yeah, and maybe as a follow-up question, obviously, if a peripheral hospital would be interested in joining the consortium, are you open to these sort of hospitals as well, or?
Yes. So, yeah, I think we are hoping that we will be able to scale up. It's not easy to include every hospital because, of course, of limited resources, but that's what we are hoping will happen. Yeah.
That's fantastic. Yeah. So I guess, I mean, in terms of the standard of care guidelines, they obviously go from the best case scenario. Um, but like, would you kind of like stagger these guidelines to say, well, if you don't have these resources available, then you can still do this? Or are these standard of care guidelines fairly adaptable for any hospitals? Or what are your thoughts on that?
I would like really to call one of my colleagues to comment on that. Josephine, please, she is the coordinator for standards of care. If you are able to talk and comment.
Let me see. Do you want to raise your hand? Because then I can unmute you easier. That will be fantastic. Josephine,
Yes, she's
okay.
there.
There you go, yeah. So, fantastic. There you go, Josephine.
Thank you very much. Good morning, good afternoon, everyone. So with regards to the guidelines that we've managed to develop as well as disseminate, as well as Dr. Siana already mentioned that they're actually yes being used at the university and national levels, but we also have they're actually categorized according to the hospital levels. So we have the tertiary referral, secondary referral, primary referral, and then go down to the community level. So these guidelines can actually being adopted by any facility, any country, in order to actually treat these patients. So we can actually continue doing the capacity building for other healthcare levels that are down to primary, to the dispensary and healthcare levels, but also we have guidelines for the community home-based. So even patients and parents themselves, they have their own individual guidelines that they can use to treat themselves when they're at home. I hope that I've answered your question. Thank you.
Yeah, that's phenomenal. And I mean, maybe like just to check, like, do you also get the government support? Because they obviously can often help to make sure that these guidelines are being implemented. Do you currently work with the local governments or?
Yes, indeed. Among the aims for the consortium also is to be able to sustain the activities that we're doing at the consortium. So we're also collaborating with Ministry of Health from various countries. And for instance, right now for Tanzania as well as Nigeria, they have the guidelines that have been developed using the existing SickleInAfrica guidelines. So right now, for instance, I will talk more on Tanzania because I'm here. We've been able to work around with Ministry of Health, and the dissemination have gone through from the two major regions that we started with, but right now it's more than 10 regions that are actually being trained and are in use of these guidelines. So I know that Nigeria is doing the same. Zambia also has started communication with the Ministry of Health and making sure that this is being sustainable in a way. Thank you.
That's fantastic. Thank you so much, Josephine. Dr. Nkya, we also have a question from Petros Kontouris, who says, great work, thank you. Regarding the registry, what type of information is collected for all patients? And then the second question is the CRF publicly available?
Okay. Thank you very much, Petros, for those questions. Again, I will see if my colleague Upendo is on the call. I'm not sure if she is, but at the moment we agreed. If Upendo, you are here, please, or anyone from DCCCC, you can feel free to raise your hand and contribute. But we did agreed to collect some basic information, so demographic information of the patient, some clinical information, and a few laboratory parameters. And we agreed for this so that we have harmonized elements collected across the consortium. We are not limited by resources, but one of the things that we are hoping to do is really to be able to continue to enhance the information that we are currently collecting through the research that we are doing. So all the patients that will be enrolled into the different research studies where we will have extensive additional data elements collected will contribute to the registry. But also we are hoping to seek more resources to be able to have more elements, data elements collected into the registry. So the CRF, I'm not so sure if it's available publicly, but this is something that we can explore with the Data Coordinating Center, the DCC, and the steering committee. So what we do is, if there is any interest in terms of collaborating, it is tabled through the steering committee body of the consortium. And once that is approved or agreed upon, then we move on to partner. Thank you.
Fantastic. Thank you very much. Maybe for the registry as well, will you include follow-up data for the ones who implemented the standard of care guidelines to see if there have been improvements in terms of the care?
Yeah, so that's a good point. So I think that's possible. This is something that we can definitely be able to do as a longitudinal or prospective studies to see what we are doing now is probably just been mentioned for standards of care at the moment is actually trying to assess how much integration we have across the consortium, how many people are actually using the standards of care guidelines across the consortium. And this in itself is a study that we want to be able to implement properly so that it can inform us of how much more we need to do in terms of ensuring that the utilization of the standards of care are optimum, or is what we envision. But I agree that this is something that we can also take up in terms of how our registry has actually enhanced standards of care delivery. Yeah.
That's fantastic. Thank you so much. Does anyone else have any more questions? If you would put them please in the chat or raise your hand. If not, maybe in the meanwhile, Dr. Nkya, if somebody would like to get in touch to learn more, what's the best way to get in touch with you?
Okay, so so I think the best way is really to reach out to the consortium. I'm part of that, so whoever is interested is feel free to reach out, and then I will be able to channel the request or the interest to properly to the right bodies. Yeah.
Fantastic. That's fantastic.
Yeah,
because
maybe just to say that we are also looking for collaborations. We are really keen to build collaborations around the work that we are doing. So really, we are looking forward for people reaching out and see how we can work together.
Definitely, yeah. It's all about collaboration, isn't it?
Yes, exactly.
Okay. So if there are no more questions, this webinar will actually be recorded. So Dr. Nkya, there might be some follow-up questions from people who will be in touch via email who've watched the recording. But it was an absolute fascinating presentation today. It really aligns well with the aims of the Helios project as well, to harmonize the care for sickle cell patients. It's not an easy task, but it's a very exciting task to do the best for patients. So thank you so much for all your effort and for the presentation today. It was really, really interesting, and we look forward to collaborating then.
Yes, thank you so much for having us as SickleInAfrica in this platform. thank you for the invitation. And really looking forward to work together. Thank you so much.
That's wonderful. We got a question actually from Professor Makani, who's asking how to join Helios. So Petros, if I can possibly unmute you just for a brief moment, is that okay? Hopefully, if you could just share what the best way is to share to join Helios.
Hi everyone, can you hear me?
Yes, it's perfect. Thank you.
Thank you, Stephanie, and thank you, Siana, for this great presentation. So the Helios project is available to anyone that is interested to join. We can just post, Soterula has just posted the link where anyone can apply. So what is important to mention here is that in Helios, people join as individuals. You don't join as organization. So you can join, you can get your colleagues to join and so on. You can participate freely in all the activities, especially the virtual ones. And just to mention as well that we are also very open to collaborating. We are also having a specific position in Helios for global collaboration and harmonization with other consortia that are doing similar work. So I did a question for the registry, for example. Maybe there is room for harmonization there, but I'm pretty sure that for all the topics that Siana mentioned in the presentation, there is a lot of room for collaboration and harmonization. I see a question by Julie Makani about the relationship between Helios and Inherent. So yes, thank you for this question. So Helios was created as an initiative of the Inherent network, but the focus of the networks are a bit different. So Inherent is focused on genetic modifiers for hemoglobinopathy, so it's a research study, while Helios tries to cover through networking and training all the aspects of the topics that are related to hemoglobinopathies: genetics, clinical management, data management, education and training, dissemination and outreach. So all the topics are involved in the Helios project. And as I said, through networking and training, we don't have funding for research. We only have funding for this kind of networking and training activities.
Thank you, Petros.
Thank you.
Okay. Does anyone else have any questions for Dr. Nkya or for Petros about the Helios project?
So,
Okay.
not a question, really a comment probably. And thank you so much, Professor Makani, for the questions. And yeah, so that's really great that we can start thinking of ways that we can collaborate. And probably we should probably plan for a follow-up meeting after we have thought a little bit of ways that we can collaborate. As I said, we're really open to collaborations, and it will be great to have a follow-up meeting afterwards. Thank you.
That's wonderful. Thank you so much. Okay.
Thank you, Siana. For sure, we will try to arrange a meeting to discuss potential collaboration. So you will get an email from us soon.
Thank you, Petros.
Thank you.
Okay, does anyone else have any more questions? If not, well, we will share the recording of this webinar. So if you have any questions, then I'm sure Dr. Nkya will be happy to receive an email from you. But thank you so much, everyone, for joining today. It was a fantastic presentation, Dr. Nkya. So thank you so much again. And we look forward to continuing to follow your work and keep up the great work that you're doing. Thank you so much.
Thank you very much.
Thank you.
Yeah, thanks to everyone also. Bye-bye.
Thank you. Bye-bye.